Hello and welcome to my channel. I am Dr. M.D.Zafar and I talk about the core concepts related to the IMM surgery and allied. Today, the topic of our discussion is necrotizing fasciitis. Necrotizing fasciitis, if it is present in the anterior abdominal wall, it is named as Milanese gangrene. If the same is present in the perineum, it is named as the Fournier's gangrene. So now we'll talk about what it really is. So necrotizing fasciitis is a rapidly progressive, life-threatening soft tissue infection that involves the fascia as well as the subcutaneous tissue, resulting into tissue necrosis. And remember, it is a surgical emergency. So the key findings in necrotizing fasciitis is that it has a rapid onset. The patient will be in severe pain after any injury or wound. There will be spread of infection in different facial planes and it has high mortality. So it needs to be diagnosed and treated effectively. Regarding its etiology and types, type 1 is polymicrobial, which is more common, around 70 to 80%, and in this both aerobes and anaerobes will be found. So it is common in diabetics, post-operative wounds, and specifically in the perineal infections, that is the Fournier's gangrene. Then we have another type, the type 2. It is monomicrobial and the most important bacteria is the group A, Streptococcus, and other name for this is the Streptococcus pyogenes. Now it is found in healthy individuals after minor trauma. So type 1 is polymicrobial and it is found in immunocompromised patients, but type 2 is single organism based and it is found in healthy bones after minor trauma. So type 3 is a marine related, that is the patient will be having a lot of seawater exposure and the organism will be Vibrio vulnificus. So talking about the clinical features, there will be sudden and severe pain associated with swelling, erythema and warmth initially, followed by skin discoloration. The high yield finding on the clinics is the presence of crepitus, that is the gas forming infection. Along with this, the patient can also develop features of sepsis that includes fever, tachycardia and hypertension, and it rapidly progresses towards shock and multi-organ failure. So it needs to be diagnosed within time. In terms of diagnosis, the very first thing is clinical. It is one of the clinical diagnosis, but the certain labs are important. We have the blood test. They will be representative of the sepsis that includes high WBC count, increase in the CRP, deranged renal function test, and various others. However, researchers have devised a score that is known as the laboratory risk indicator for necrotizing fasciitis. Different factors have different values and their score is cumulatively added at the end to see the development of necrotizing fasciitis. So in this score, we have first of all the C-reactive protein. If it is less than 150, we have 0 score, but if it is more than 150, then the score becomes 4. So it has a strong presence in relationship to necrotizing fasciitis. In terms of the WBCs, if they are less than 15,000, we have no score. But if it is from 15 to 25, we have 1 score. More than 25 has 2 score. Then hemoglobin. Hemoglobin, if it is more than 13.5, that is normal, we have 0 score. But if it is between 11 to 13.5, we have 1 score. And if it is less than 11, then the score will be 2. Similarly, for sodium, if it is normal, that is more than 135, the score will be 0. However, if the sodium is less than 135, the score will jump to 2. Regarding creatinine, if it is less than 1.6, there is no score. However, if it is more than 1.6 milligram per deciliter, then the score will come to 2. Then we have glucose. If the glucose value is less than 180, we have 0 score, but if it is more than 180 milligram per deciliter, then the score will be 1. So now we will add all these scores and go for the interpretation of this score. So if the score is less than 6, the patient is having low risk, But if it is between 6 to 7, then there is an intermediate risk. And if the score is more than 8, then the patient is a higher risk of developing necrotizing fasciitis. However, we can also use CT scan and MRI to identify gas in soft tissues and facial plane edema. So the definitive diagnosis is made on the surgical grounds while performing the surgical exploration, which will show necrotic fascia and no bleeding and purulent discharge. In terms of the management, we have emergency surgical debridement as the cornerstone for the management of necrotizing fasciitis. Immediate and aggressive removal of necrotic tissue is the mainstay of treatment, followed by broad spectrum IV antibiotics. Different antibiotics are used: piperacillin along with tazobactam or carbapenem, followed by clindamycin or vancomycin if there is MRSA coverage required. Apart from these two, supportive care like ICU management, fluid resuscitation, vasopressors if the patient is in shock, and nutrition support can also be of help. In terms of prognosis, 20 to 40% mortality if the treatment is delayed. So, prognosis depends upon early diagnosis, rapid surgery, and appropriate antibiotics. So, I hope I have cleared your concept related to the necrotizing fasciitis, and they will be helpful in terms of solving MCQs. So, thank you very much for listening.